EM board bombs.
EM Board Bombs, we are back with another episode. Dr. Wasiski-Kuhn joining us. Woohoo. Celebrate.
Hello.
Coming to us live from the essentially Cheyenne Mountain Complex with her internet connection. Every time we record, there is such a slow upload speed, and I'm beginning to think that she is literally recording from NORAD. If you know, you know, in Colorado. People in Colorado know.
It's true.
Hey, so for every 15-minute episode in Board Bombs, you get bite-sized learning, we like to call it. And we tell you what you need to know. And that comes with boards and hashtag EM Life. Wow, what a showing at SAM. I know I'm still talking about like 2 weeks after, but we met a lot of fun people. We really appreciate the support, really humbled. Marlena, you were missed. People were asking about you. They wonder how you put up with Iltifat and I. And I told them I don't know how.
From a distance.
Yeah, the voice of reason. That's what we call her. Holding us back and our crazy ideas. Anyway. Hey, so this is your thing. You had such a great topic idea for today, and this is going to go over really well. It's a home run. And so we're doing something a little different, and it is centered around boards, but certainly there's always a real-life connection. We try to make this as believable as possible. There's nothing worse than listening to a board study resource, and it's telling you all these things, and then you get to real life, and like, yeah, that just doesn't, we don't do that here. You know, that's not... This isn't ABEM or the hospital, but in real life, we like to share both. We like to tell you what is on the tests, what is in real life. And so we have a really killer episode here. We're covering essentially 4 different multiple choice questions here, and they all have to do with just rapid fire. What is the best next step, and what is the emergent upgrade to these patients?
Right, exactly. I thought of this because I had someone tell me once during my medical training that I think they were trying to give this to me as some constructive criticism, but they told me I had a bias towards action, and I was like, thank you. And that's not how they meant me to take it. But, in emergency medicine, there's a lot of conditions where you need to stop thinking and act, where you need to take emergency action. And those are the patients where on the exam, the writers want to try and trap you into ordering things like getting labs and imaging and waiting to talk to other people about it, waiting to do something. But the correct answer is to act now. So that's what we're going to talk about today.
Totally. Cool. Let's dive into it. So I'll read case number 1 here. You have a 34-year-old male presenting to the ED after several hours of yard work, which he says that he has to do on a regular basis in order for his mom to keep letting him live in her basement. He is complaining of abdominal pain, multiple episodes of vomiting, and diffuse urticarial rash. His blood pressure is normal. His oxygen saturation is 99%. He's not wheezing. What's the best next step? Choice A, diphenhydramine. Choice B, IV methylprednisone. Choice C, IM epi. Choice D, observation. What's the correct answer, Dr. Wasiski-Kuhn?
Correct answer here is C, IM epinephrine.
Oh, no hypotension. Why are we giving epi? This is such a discussion that happens like on a daily basis at every
they're like,
ER I've worked at.
Not hypotensive. He's not even wheezing. His O2 sat is 99. Why are we giving him epi? Okay, because he has urticaria and he has vomiting, and that's 2 distinct systems, and we know that that's anaphylaxis.
Totally. Yeah, so the big board trap here is, as you said, the hypotension, which I have maybe seen once, maybe.
I know.
And I've seen a lot of anaphylaxis, and it's not that. And wheezing also is not the most common. I would say the most common is this subtle, like, I can't really swallow that well, like a globus sensation. Like, I feel like I have to catch, the back, something stuck in the back of my throat feeling. Or they can't swallow fully. I mean, those are definitely, speak for themselves, concerning signs. But the one here in this case was really subtle, but just understand people will hesitate. So your immediate action is what?
Immediately give IM epinephrine. Anaphylaxis dose of epinephrine is 0.5 mg.
Yeah. For full disclosure, for all the pharmacists listening, it's 0.01 milligrams per kilogram, but it's a max dose of 0.5. And honestly, most adults are going to hit that. So it's going to be 0.5 milligrams. in the thigh. IM epi, totally the answer here. Used to be 0.3, we went up because of underdosing. Cool. So coaching, subtle presentation, skin, GI symptoms. Not all anaphylaxis has airway management involvement. Cool. Next question. Let's dive in. Why don't you read this one?
All right. A 28-year-old female presents with severe left arm pain that began yesterday and has been rapidly worsening. She is febrile, tachycardic, and she appears uncomfortable. Her friend, who accompanies her, states she knew something was wrong when the patient stopped using her left arm to live stream their latest Getting Ready With Me video. Examination reveals severe pain with movement of the arm, but the skin appears normal without any crepitus, fluctuant, or significant erythema. What is your next best step? Is it A, CT scan of the extremity, B, broad laboratory evaluation, including an ESR and a CRP, C, emergency surgical consultation, or D, MRI of the extremity? While you're thinking about that, you know what I'm thinking about? I'm thinking about EM rapid
Acing the
bombs
boards.
and acing my boards and how I just totally crushed them because I listened to EM rapid bombs and I got tons of rapid repetition of great cases, kind of like this one we're talking about now, where it's lots of short pearls over and over. You learn the things you need to know. I think we're about to hit 600 episodes covering
2 away,
all
baby.
the
2
things.
episodes away.
Yeah. Everything you could possibly think of.
Yeah.
emboardbombs.com. You can check out EM Rapid Bombs that way. You'll love it.
You know, it's crazy. There was a talk at SAM about how the board rates have gone down. Like all the PDs in the country were at that meeting. And part of me wanted to just rush on the stage and just hold up a big sign that said sign up for EM Rapid Bombs. We've had so many residency sign-up group subscriptions, and there's such a difference. And program directors will literally send us testimonials and literally say, hey, our residents are doing fantastic on the IT now. We've had this for over a year. Definitely going to renew it. And we offer group discounts, too. So email us and let us know. But it's a fantastic resource. So check us out. Cool. So correct answer here. This patient with this skin soft tissue mass is going to be choice C, emergency surgery consultation. You saw this coming a mile away. Hopefully people listening to this were like, definitely that's the case, but they're probably rolling their eyes as well because they're like, in real life, obviously we're gonna get the, all the labs and the CT because the surgeon asked for it, and that's on them in terms of consulting them. But when you consult surgery, and we've talked about this before, I think you and I did the Neck Fash podcast years ago, and then there was a recent one we did too. The conversation you need to have, and one of my great mentors from Wake Forest, Mary Claire O'Brien, shout out to the GOAT, she told me this as a resident. She said, when you call, you clearly speak in one sentence and you say, I am worried about a necrotizing infection. And you just straight up say it. You don't sugarcoat it around. You don't pussyfoot around. You just say, I am concerned about this patient having a necrotizing infection. I need you to come and see them. And that gets their attention. It shows that you're firm and you're direct. And, you ask please and thank you, of course. And if they come down and see the patient, they're like, I'm not too worried about that. I want to get a CT first. Okay. Always advocate for your patient. But having them come downstairs and not this kind of wishy-washy, like, it would feel better if you just came to look at him. I'm not sure either. It's the big thing of just being the concern, right? And it's that pain out of proportion. What else you got?
Yep. I would say that even when you make that call and they start telling you to order things, you can be like, yeah, sure, happy to order that stuff, but come see them now. You can acquiesce and still get what you want.
Exactly. And I would say that, again, the picture's worth 1,000 words. So them coming to see that patient, being in the room, the smells, the sights, seeing what you're concerned about, it speaks volumes versus talking about it over the phone. Even sending a photo sometimes doesn't dramatically change the direction of that conversation. So again, you're right, emphasizing the importance of them seeing the patient. The trap, of course, is just more imaging. The bedside ultrasound, as much as I love bedside ultrasound, it's not going to be definitive here. CT as well, delays, not definitive. MRI, oh my God. Talk about flunking your boards.
Oh my God, that's funny.
And then, waiting for labs, like a ProCal. I think someone told me the other day about some relationship with like ProCals and like neck fash and prognostication. I was like, okay, well, that's great, but let's not get this complicated here. So, okay, so immediate action, just like compartment syndrome. This is pain on proportion on exam. You're calling surgery immediately.
Yeah,
Sweet.
and remember, in real life, your consults are time-stamped. This stuff matters. Case 3. A 25-year-old female presents to the ED shortly after delivering a baby at home. She is having profuse vaginal bleeding. She says that she named her baby Richter Zane. She chose the name because of a concert she went to when she was 15 years old with her first boyfriend, and she is quick to say to the man in the room is not that boyfriend, but it's the one who got away. Vital
Always
signs
awkward
are
when
heart.
this situation happens. Always happens. How often does that happen to you? It's like awkward. They mention like their previous partner or dad or something, and you're like, the guy's just like looking around in the room, eating their Wendy's or something, and
You're just like, sure, yeah, you definitely didn't hear that. Me
Sure,
neither.
yeah.
Let's move on.
exactly cool. All right, what are
Her
the
vital
signs?
signs: heart rate of 142, pressure 78/42, respirations of 28. What is your next best step? Is it A, oxytocin administration, B, TXA administration, C, massive transfusion protocol, or D, pelvic ultrasound?
So correct answer here, thinking about the global picture, is choice C, massive transfusion. So in reality, again, we understand a lot of people work at hospitals that don't have massive transfusion. You're working at critical access places that have limited blood. You have like 4 bags and that's all you get for like 48 hours or something. So we get it. You know, this is exactly where Marlena works, outside the Cheyenne Mountain Complex. So you have probably 1 bag to give of PRBC. Okay, great. Just give blood. That's the answer, is blood.
Yeah.
This patient's blood pressure 78/42. Now, conveniently here, one of the answer choices, let's say, should have been bimanual, uterine massage, which is the correct answer also. It's kind of like source control in a trauma patient scenario. We didn't put that on purpose because I don't think the boards would do something like that. Now, if they say, what's the best immediate step? What's the next immediate step? Yeah, bimanual uterine massage is the correct answer. But it's saying here, out of all these options, what is the most important downstream consequence? And you're addressing that low blood pressure. That is giving blood.
Next best.
Now, the trap
step.
that the boards will get you in here is this picking the cutting edge sweet answer here, which is the TXA, right? And yeah, TXA definitely has a role in postpartum bleeding, but it is not the definitive treatment for postpartum bleeding. It's not even the top 2. So the top 2 are going to be give blood and bimanual uterine massage. And then you give TXA. Then you, of course, call OB. And the pelvic ultrasound again, later on, looking for retained products, but not the immediate next step for this patient.
When a patient is crashing, you should always resuscitate them first. This goes for pretty much every emergency patient ever. So
Yeah, we did. I think, again, we've done so many episodes now, it's crazy, right? We did a topic on this several months ago, and it was like the 5-minute resus for a sick patient, undifferentiated shock.
Yes.
And the
Great
answer is
episode.
you give a liter of fluid. And it's like, that's what it is. And who cares? You don't know what type of shock it is yet, but you are literally reacting at that moment for the first 5 minutes. And that's fine. And you're not going to do anything wrong with giving. I think every patient in the world that's in shock will get 1 liter of fluid if they come to the emergency department, because you just don't know yet, and you're just reacting to the situation. But yes, you're right. At that point, you're moving on and moving to your goal-directed therapy. So cool. I'm going to stump you on this last one. You ready?
Okay.
A 22-year-old collegiate football player is brought to the ED after collapsing during preseason practice. He is confused, diaphoretic, and has a core temp of 106 Fahrenheit. That's 41.1 degrees Celsius for you Canadians. His teammates are crowding the lobby, causing a distinct and strong odor. Hopefully asking if he will be able to crush brewskis at the tiki party tonight. And hopefully you'll be invited too. What is the most effective method for rapidly reducing this patient's temp? Choice A, ice packs to the groin and axillae. Choice B, cooling blanket. Choice C, evaporative cooling with a mist and a fan. Choice D, cold water immersion.
The most effective method. Choice D, cold water immersion. Put them in the tank.
Totally right. Now, does your ED have one of these? Probably not. There are some makeshift discussions of using some tarps and bags, and that's great, and it's like a viral Instagram content thing. You can check it out. That's all well and good on the boards. They're just going off literally what's the best method. And the best method is always cold water immersion. Now, realistically, you may not have that. You may have to do cooling blankets, evaporative cooling, some ice packs, strategically placed, as they say, strategic ice packing. And that all is great. But again, the best answer, cold water immersion. What else you got?
Traps here. Giving him Tylenol and starting sepsis workup. Come on. This is an athlete that just came from a football practice.
Yeah.
Please don't. Trend the
Yeah,
lactate.
that's not good.
No. He probably
But you
has an
never know.
elevated lactate.
You never know. You never know. What if they were septic before they went to football practice? Yeah.
I guarantee your EMR is going to give you a sepsis alert on this patient.
Yeah.
Don't be fooled.
Bingo. Yeah, so the treatment is definitely lowering the temperature. Yeah. Aggressive cooling. Aggressive as possible, yeah. And one key caveat here is if they're an elderly patient, they may not be diaphoretic, right? Because they are more of the non-exertional type of heat stroke. Like I always picture some like apartment in like New York, and they're on like the 10th floor, and they have like a little fan, and that's it. And their AC unit isn't working on the window. Sorry to anybody living in New York. You can write us if that's true. But I can imagine how like oppressive certain like concrete jungle heat situations are.
Yeah.
But this is an exertional heat overload issue. So why don't you wrap us up here? This is some really awesome pearls. We have like 4 key points here to make that you are totally right here. It's the think later, act first in certain situations in emergency medicine, which makes it a very distinct field.
Yeah. Obey your bias towards action. Notice the patterns that we've talked about here today. The boards know like none of these were a diagnostic conundrum. You knew what they were, but what the question's really asking about is whether you're going to delay definitive treatment to get like more supportive information of the diagnosis, which you already knew. You knew the diagnosis of these questions as we read them to you. So some immediate actions we went through today. If you see anaphylaxis, give IM epi. If you see neck fash, call surgery. If you see postpartum hemorrhage, activate massive transfusion and get source control. If you see heat stroke, activate aggressive cooling protocols. Stop ordering extra tests. Start treatment right away.
Totally. Awesome. What other questions you got?
I want to know about your favorite ocean animal, Dr. Briggs.
Oh my gosh, the Portuguese man of war. Yes. So stay tuned, ladies and gentlemen, because coming down the pipe here, EM Board Bombs, there is a fascinating episode. David Attenborough was not available, so Marlena Wasiski-Kuhn is taking over. And she'll be talking about the Portuguese man of war in our next episode, hopefully. But yes, that is my favorite, one of my favorite sea animals. Oh, absolutely. I could go on for hours about it. They'll probably just be
Very
laughing
exciting.
right now. He's like, yeah, that's pretty classic. Can't wait to hear about it. All right, sign up for EM Board Moms. Go to emboardmoms.com. Again, we accept residency discount, group discounts. We would love to hear from you. Comments, questions, concerns. If you named your son Richter Zane, we're sorry. It's a fine name. You all have a wonderful evening, wonderful day. We'll see you next time.